serious functions. My talk today is about herpes simplex keratitis, which is not that simplex. Herpes simplex virus is one of human herpes viruses that can cause different human diseases, and they can achieve a state of latency in the process of inactivity with occasional reactivation. Herpes simplex virus is double-stranded DNA. It is a neurotropic virus that attacks nervous system preferentially. The epidemiology of the keratitis, it is a leading infectious cause of blindness in the world and is the second cause of blindness after cataract in developing countries. In developed countries, the incidence from 10 to 30 cases per 100,000 population per year, while the global incidence is almost 1.5 million cases, with 40,000 new cases per year, and the recurrence rate after the first episode reaches to up to 63.2% at 20 years. The infection starts primarily during the childhood commonly and usually, and it's commonly asymptomatic but may be associated with oral vesicles, upper respiratory tract manifestations, ocular surface involvement in form of conjunctivitis and peripheral conjunctivitis. After that, the virus moves retrograde through the sensory nerves to reach the trigeminal ganglion, at which it inhibits the host immune response through different mechanisms, mainly through inhibition of type 1 interferon to achieve a state of latency. Various stimuli can result in activation of herpes simplex virus, and after that it moves anterograde through the same sensory nerves to reach to the cornea, and in the cornea it can affect different layers. Commonly the epithelium, stroma and endothelium also can be affected. Herpes simplex keratitis is in 10% of cases is bilateral, especially in immunocompromised patients, in children, and also in atopic individuals. The first common presentation of herpetic keratitis is the epithelial disease, epitheliitis. Due to active viral replication, the virus is present in the corneal epithelium, characterized by single or multiple arborizing dendritic epithelial ulcers with terminal bulbs and raised above the corneal surface. These bulbs may coalesce to form a geographic ulcer, especially with the use of topical steroids and also in immunocompromised patients. We have to differentiate the dendrites. As in cases of herpes zoster ophthalmicus, the dendrites are more epithelial, no central ulcer, negative for fluorescein staining with no terminal bulbs. And also in early infectious cases, as in cases of fungal and acanthamoeba keratitis, at these cases, if we suspected herpes simplex virus, it will not respond to topical treatment. So scraping for staining and for culture is mandatory to achieve the diagnosis. The treatment of epithelial keratitis due to active viral replication at the surface of the cornea on the epithelium, so it is by topical antiviral agents as acyclovir or ganciclovir 5 times daily for maximum of 2 weeks. Because prolonged treatment results in ocular surface toxicity up to neurotrophic disease. Oral acyclovir may be indicated in immunocompromised patients and in children to prevent the development of viremia that may result in encephalitis and meningitis. Debridement with mechanical removal of virus containing epithelial cells may shorten the duration of treatment, but it is not effective if alone. I have to remind you about absolute contraindication of topical steroids in epithelial disease, and the healing rate is over 90% of cases with this treatment. The second presentation is the stromal keratitis, which is immune response to herpes simplex virus antigen in the stroma and infiltration of the stroma by inflammatory cells. It is of 2 types, either necrotizing stromal keratitis characterized by the presence of epithelial defect, stromal melting and the necrosis up to perforation, and it is immune mediated and maybe due to viral replication. The second type is non-necrotizing epithelial keratitis without any epithelial defect, no stromal melting, characterized by deep corneal vascularization that may result into stromal hemorrhage and lipid keratopathy in untreated cases. The role of antiviral therapy is systemic, and examination of corneal anesthesia of corneal sensation is important to confirm the diagnosis. A herpes simplex virus marginal keratitis is a special rare form of stromal and epithelial disease, very difficult to be differentiated from other causes of marginal keratitis as a PUK, but diminished corneal sensation may be a clue for the differential diagnosis, and the PCR for the viral DNA is sometimes available here, يعني غالبا مش موجودة, but may be used to differentiate. The endotheliitis or disciform keratitis is also a host immune response at the level of the endothelium, results in endothelial dysfunction with or without the immune ring in the stroma. It's either diffuse or focal and linear, associated with anterior chamber reaction in form of keratic precipitates, and intraocular pressure may be elevated due to associated trabeculitis. The treatment is by topical steroids with complete systemic acyclovir coverage, and examination of corneal sensation will be affected. The endotheliitis is endothelial specific disorder, mainly caused by virus etiologies, as herpes simplex virus and varicella zoster virus are very difficult to be differentiated, and cytomegalovirus endotheliitis, which is characterized by the presence of coin-shaped endothelial lesions. We have two diagnostic dilemmas. The first one, during active diseases in which the patient has an ulcer, not having a classic dendritic appearance without a prior confirmed diagnosis, and corneas with a known history of herpes simplex virus developed a new epithelial defect without characteristic features. In these cases, scraping is important and is mandatory because it may be a co-infection. Herpes simplex virus is the most common risk factor for fungal keratitis, and also may be a different infection. The viral detection, the DNA by PCR, the virus itself by viral culture, the antigen by immunohistochemistry, and the antibodies by serology. The second challenge in diagnosis in inactive disease with the presence of corneal scars, either it's herpetic in origin or not, especially before ocular surgeries as in keratoplasty, to explain the prognosis to the patient, cross-linking, refractive procedures, PTK, and in cataract surgery, proper history taking from a patient about the recurrent attacks of keratitis, and examination of corneal sensation is important to exclude herpetic, and if positive and the corneal sensation is diminished, we have to consider prophylactic systemic antiviral therapy. So to sum up the treatment of herpetic keratitis, we have to be wise, layer-wise. In epithelial disease, the treatment is by topical antiviral, and systemic only in immune-compromised and children. Also, the primary, the infection may be treated, epithelial disease, by systemic if the topical treatment unavailable. Stromal keratitis with ulceration, the treatment is by topical steroids with complete antiviral systemic coverage in prophylactic dose. Stromal keratitis with ulceration, the necrotizing type, with topical steroids plus oral antiviral in therapeutic doses, and endothelial keratitis has the similar management to necrotizing stromal keratitis. The antiviral agents for herpetic keratitis here in Egypt, acyclovir, and the therapeutic dose is 400 milligrams 3 to 5 times daily, and in children we have to calculate the dose, 12 to 15 milligrams per kg per day, divided into 3 to 5 doses, and the prophylactic dose is 400 milligrams twice daily. Acyclovir has a higher bioavailability and a steadier serum level, and the dose is 500 milligrams 3 times daily in therapeutic dose, and the prophylaxis is just single tablet per day. Topical steroid administration based on herpetic eye diseases study. The potency of a steroid is according to the level of corneal inflammation as well as the degree of corneal inflammation. In the presence of epithelial defect, delay the onset of steroid use. Systemic antiviral coverage, احنا roughly بنحسبها, the single drop of topical steroid must be covered with at least 200 milligrams of systemic acyclovir with maximum 4 drops of steroids. And instead of sudden discontinuation of a stronger steroid, consider to replace with a weaker one to avoid rebound inflammation with a gradual tapering over at least 10 weeks. في patients maybe for life بيبقوا ماشيين على a single drop of topical steroid with prophylaxis therapy. For how long can I do a prophylaxis using systemic acyclovir? The herpetic eye disease study group concluded the long-term suppressive oral acyclovir therapy is important to reduce the relapses, especially in patients with frequent reactivation in the central diseases and in cases of post-keratoplasty, and those patients we can make a prophylaxis for more than 1 year. Not only a 1 year, but more than 1 year, even for life. The acyclovir is a safe drug systemically. The neurotrophic ulcer is a different entity, no viral activation, lower inflammatory level, mainly due to chronic viral trigeminal ganglionitis, and Dewey et al. Have proposed a 3-stage classification system, mild, moderate, and severe disease according to the level of stromal involvement. Also, examination of corneal sensation is important because the corneal sensation will be diminished or absent in such cases. Management of advanced perforated cases, we have a small peripheral perforation using a tissue adhesive with bandage contact lens or tissue adhesive with overlying amniotic membrane graft to promote the healing may be needed. Large peripheral perforations, patchy grafts, and eccentric grafts may give the solution for the case, and it may be temporary for optical grafts. Hot therapeutic keratoplasty and corneoscleral grafts are indicated in patients with advanced corneal melting and large central corneal perforation, as those cases managed with corneoscleral grafting. And if it fails, it is to save the globe and for a potential optical keratoplasty. We have to differentiate the herpes simplex ophthalmicus and the herpes zoster ophthalmicus. The herpes zoster ophthalmicus occur mainly in immunocompromised patients with obvious skin lesions, shingles. The epithelial disease easy to be differentiated and no role of topical antivirals. Stromal and endothelial disease are very difficult to be differentiated. Serological tests and PCR may be helpful to differentiate, and whenever in doubt, overtreat, as varicella zoster virus with 800 milligrams systemic acyclovir 5 times daily for 1 month. In COVID-19 pandemic, we have seen an increased incidence of herpes simplex virus reactivation, and it's related not only to the infection itself, but also to drugs used to treat patients with COVID-19 as a steroid and tocilizumab, as well as in patients with vaccination of COVID-19, herpes simplex keratitis activation and herpes simplex virus activation increased. So, take-home messages: the herpes simplex keratitis is a major cause of blindness in developing countries. The multiform occurrence results in challenges in diagnosis, and any patient with a stromal scar examine corneal sensation first before prescribing topical steroids to avoid reactivation. While managing cases of herpes simplex keratitis, please be wise, layer-wise. Ocular surface homeostasis should be always considered while treating patients with herpes simplex keratitis to avoid neurotrophic disease. And thank you very much for your time.